Friends, so good evening, friends. We are now live on the important update sessions. So immediately after getting the new edition, we waited long period for getting a PDF, but so far we could not get the PDF. So it is getting little time for us to do all the updates. So I'm starting with Sabiston updates on esophagus and stomach. These are all very small sessions. I request this update should be read only by people who have already completed 21st edition. So which are changed in 21st to 22nd edition, only the updates we are discussing in this program. We are not discussing everything which is there in the Sabiston 22nd edition, because already we have done complete videos in the tutorials about Sabiston 21st. This is just to help you, those who are prepared from Sabiston 21st, to update the new points. Good evening all. Let us start with the esophagus updates. See, as usual, you know very well, most of the updates are from oncosurgery. Onco part of every chapter has more updates, but the basic non-onco part, there is no bigger updates. And this Sabiston is an extraordinary edition. We could see a lot of concise content in this. Unwanted lot of discussions are being removed, and many interesting chapters are updated, and many unwanted chapters are removed in this Sabiston. So if you are going to read for NEET-SS 2026, not for this year, and you are going for 2026, you can throw Sabiston 21st edition and you can read only this edition, 22nd edition. There are not big updates. We are ongoing the material. So as of now, esophagus and stomach, we have some 20 to 25 updates. I'm going to discuss those updates alone now. A new name added in 22nd edition, Gubarov valves. What is Gubarov valve? It is a thickening of the esophageal mucosa at the esophagogastric junction, acting as a cushion and keeping the area closed. This is called as Gubarov valves. Please remember that is called as Gubarov valves. Thickening of the esophageal mucosa at the esophagogastric junction, acting as a cushion and keeping the area closed. So Gubarov valve is the thickened mucosa at the EJ junction. Just remember, I hope you know where is Heaster valves. Heaster valves are seen in cystic duct, Gerlach valve seen in appendix, then Bauhin valve is ileocecal valve. So these are all other valves. Houston valve in rectum. So those are all basic things. Houston valve rectum, Heaster valve in cystic duct, Gerlach appendix, Bauhin is ileocecal. Here is a new valve added now called as Gubarov valve. Okay. And this is a very important update. What are the indications of esophageal manometry? So esophageal manometry is not available everywhere so easily. So this is a little costly investigation, costing from 5,000 rupees to various centers charge even up to 15,000 rupees. Using 36 sensors, we have to put a catheter, ask the patient to swallow 10 times 10 ml of water and do the test. It's a more complicated test, not available in all the places, done by medical gastroenterologists. It is done for pH monitoring. Those patients whom you are going to do pH monitoring, we should know where to position the tip of the catheter. So that is for that purpose we do this manometry. Dysphagia evaluation. A patient having dysphagia, endoscopy is normal. You should evaluate with manometry. Motility disorders, diagnosis, esophageal involvement in systemic diseases like systemic sclerosis. Esophageal motility must be done always before anti-reflux surgery. Because if there is an ineffective esophageal motility, we will do partial wrapping. If there is a normal motility, we will do Nissen's 360-degree wrapping. Therefore, it should be done before anti-reflux surgery to evaluate symptomatic patients after esophageal surgery. After esophageal surgery, any patient having some symptoms, we should evaluate by means of manometry. Update number 2, a table is added in Sabiston. Distal latency is very well explained in Shackelford, though Sabiston has just mentioned a few words about distal latency in high resolution manometry. So please understand what is distal manometry. So from the time of you swallow and it crosses upper esophagus sphincter to the place of the ampulla, that is called as distal latency. So period of time between the start of upper esophageal relaxation And the change from esophageal body to epiphrenic ampulla is what determines coordination. And waves can be normal or premature. Lack of coordination is distal esophageal spasm, defined at least 20% premature contractions with normal contractile vigor. So this is very important. So lack of coordination in the distal, for example, I am swallowing. If you saw, just now I swallowed a water. From the upper esophageal relaxation to the place where the distal esophagus also will relax, that is going to be the distal latency. So lack of coordination is called as distal esophageal spasm, where 20% premature contractions are seen in this. That is one which is helpful in the distal latency. There is a new update on distal latency. So this helps to identify whether the waves are normal or premature. Okay, this is normal or premature, and this is called as distal latency. From upper esophageal sphincter relaxation to the place of lower esophageal sphincter, this time duration and the relaxation of the lower esophagus area is called as distal latency. It is updated, new update in high resolution manometry. So many other points are being removed in Sabiston. We have discussed respiratory inversion point, this, that, all those things they have removed. They simplified esophagus chapter. If you are going to read esophagus in 22nd edition, it is easiest than 21st edition. So simple chapter in this edition. Eckart score already updated in Bailey and Lau, now updated in Sabiston also. Eckart score is a post-treatment response score after myotomy or after Botox injection or after balloon dilatation in Achalasia. We have a score range from 0 to 12. Score less than 3 is a successful treatment. So based on dysphagia, regurgitation, weight loss, retrosternal pain. This is called as Eckart score. I will be sharing this PDF in our Telegram channel. So don't worry, you can just observe. I'll be sharing this PDF in our Telegram channel of our next SS channel. I'll be sharing you and also in our WhatsApp groups. It is based on dysphagia, regurgitation, weight loss, and retrosternal pain. So myotomy related update is made. So totally how long should I do myotomy? So different books had different controversy. This edition has clear 6.5 centimeter proximal to OG junction, 2.5 centimeter on the stomach side. So totally 8.5 centimeter. There is no range given here. It is mentioned 6.5 proximally, 2.5 on the stomach side is needed for achalasia. End stage achalasia. So treatment of choice is very clearly mentioned in this. Myotomy is the first line treatment. We have to go for end stage achalasia, means sigmoid or mega esophagus. Try myotomy. That is the first line treatment. If it is not responding, then we should go for esophagectomy. So esophagectomy is the toughest surgery in end stage achalasia. It is tougher than a cancer surgery. Please remember. So esophagectomy is reserved only for persistent symptomatic cases. Myotomy is the first line treatment in end stage achalasia. This is update number 6. Update number 7. It's a Killian-Jamison area. So all of you know the Killian's triangle between the cricopharynx and the thyropharynx and the midline. So cricopharynx, thyropharynx, and midline, that is Killian's triangle on the posterior neck. There is another area called as Killian-Jamison area. It's a defect in longitudinal muscle just below cricopharyngeal muscle. So if there is a cricopharyngeal muscle just below, there is a defect called as Killian-Jamison area. It is already there in Shackelford. It is now added in Sabiston also. So poem, a lot of updates on poem. So now please, 21st edition itself updated. Poem is best for type 3 achalasia. Poem is the best for type 3 achalasia. That is already a very important update. And now they have mentioned is it peroral endoscopic myotomy. Z poem that is mentioned in Sabiston 22nd edition as Z poem. This is for cutting the Zenker's septum. They create a tunnel 3 centimeter proximal. If there is a septum, create 3 centimeter above a tunnel and on both sides of the septum and ending in the normal esophagus 2 centimeter distal to the septum. And now you can cut the septum under the vision. That is a specialty of Z poem. So just remember, this is a new update. Z poem is a procedure now can be done for Zenker's. Similarly, D poem. D stands for diverticular poem, is used in the treatment of epiphrenic diverticulum. For a epiphrenic diverticulum, now it is available D poem. Just remember, that's a new update, another update for epiphrenic diverticula. You can cut the muscles by going sub-tunnel method, submucosal tunnel method. You can go and cut the muscles. So paraesophageal hernia patients, this is a very interesting update. Multi-society guidelines 2023 advises in paraesophageal hernia patients, when we do fundoplication, they are advising to do partial fundoplication because in a paraesophageal hernia, we cannot do pre-op manometry accurately. So therefore, the new edition is updated. Recent guideline says after paraesophageal hernia surgery, you should go for a partial or over complete fundoplication is better. Okay, that is very important new update. So update 11, there is a classification called as Horgan et al. Classification. It is not there even in Shackelford. It is newly updated in Sabiston. Horgan et al. Classification of fundoplication failure. Very interesting update. Since there is an increasing number of fundoplication in many places, now we have Horgan et al. Classification of failure of fundoplication. Please observe the picture. So type 1A, you can see here type 1A is a herniation of GE junction along with the wrap. So the fundoplication, what did it know? That entered into the hiatus as such. So this is probably because you didn't take a stitch with a diaphragm. So probably that is the reason it went inside. So GE junction along with the wrap went inside. Patient will have heartburn with or without dysphagia. That is type 1A. So heartburn with or without dysphagia. Type 1B, only GE junction went up. The wrap is present below, but the GE junction went up. That will cause dysphagia. Type 1A, 1B. Please understand. Since we don't have a PDF, I took a photograph and I have made here. So please observe this picture. 1A, 1B. Only GE junction went, wrapping is normal. So type 2 is herniation of the fundoplication, or in otherwise paraesophageal herniation of fundoplication. Paraesophageal herniation of fundoplication is type 2, and type 3 is a malpositioned fundoplication, as you see here. So the fundoplication is not properly in the esophagus. It has gone around the stomach itself. That is a malposition. So type 1B, 2 and 3 patients will develop dysphagia only. 1A will have heartburn. So G junction with wrap 1A. Only G junction is type 1B. Herniation of only fundoplication is type 2. And type 3 is malpositioned fundoplication. Malpositioned fundoplication. So don't forget Horgan et al. Classification of fundoplication failure. Okay. So and there is a very important update from LINX. LINX is a magnetic sphincter. They are advising where to use LINX. LINX should be used only for patients who are having A and B esophagitis. Don't use LINX for grade C and D esophagitis. And there should not be a hiatal hernia more than 3 centimeter for LINX. So no hiatal hernia more than 3 centimeter and body mass index less than 35 with adequate motility. BMI less than 35 with adequate motility. So distal wave amplification more than 35 millimeters mercury that and greater than 70% effective swallows are needed for doing this LINX. Adequate motility means what? The distal wave amplification must be more than 35 millimeters mercury and greater than 70% of the swallows. So therefore, in other words, there should be no ineffective motility. I hope you know the definition of ineffective motility. More than 50% time, the peristalsis is not completed is called as ineffective motility. You cannot do LINX for ineffective motility. So please understand, when there is a paraesophageal hernia, grade C or D esophagitis, Barrett's, patient already having dysphagia, inadequate esophageal motility, or a patient who may need a Tesla MRI, more than 1.5 Tesla of MRI needed means in these cases, I should not do LINX. This is a very important update. If the exam gets postponed beyond December or January, we can expect questions can come from 22nd edition. The exam is going to be in November. We may not expect new updates. So therefore, it all depends upon the exam update. So we are waiting for the announcement. So since there is a delay, we expect it will be in December or January because many institutes are having exam in November for their final year theory exams. Okay. So esophagus update number 13 is esophagus. So esophagus is already discussed in old edition also, transoral incisionless fundoplication. Here they mentioned a very clear material used. So polypropylene fasteners are placed between the fundus and the esophageal lumen for a 270-degree 3 centimeter fundoplication. Okay, it is a 270-degree 3 centimeter fundoplication is called as esophagus. As of now, fundoplication is favored over esophagus. As of now, fundoplication is favored over esophagus. Esophagus is not the treatment of choice for GERD. Just note it. It is 270-degree 3 centimeter fundoplication from inside. There is another update. Another stapling device with an ultrasound connected is called as Muse system. So new name like an esophagus, there is Muse. It is having an ultrasound transducer to know where we are stapling. Like a H stapler here, you will know where we are stapling. This is now recently updated Muse system. Stretta should not. I hope you know what is Stretta. Stretta means radio frequency ablation for GERD. For patients who are having severe GERD, we can go for Stretta. Stretta is RFA ablation of lower esophageal sphincter. It should not be considered in PPI refractory cases. Don't do Stretta in PPI refractory cases. RFA is avoided in PPI refractory cases. Okay, update 15. So update 16 is already there. Old edition, what old edition was saying, BMI above 35 in a bariatric patient, RYGB is a procedure of choice for instead of fundoplication. Instead of fundoplication, above 35, you should go for RYGB. But new guidelines have mentioned BMI above 35. Reflux patients, you can give options. You can give the option to the patient. Either you can do RYGB or fundoplication. Laparoscopic anti-reflux surgery. Either you can do laparoscopic anti-reflux surgery or RY. Both it can be given. But for more than 50, only RYGB is offered. So don't forget, more than 50, only RYGB is offered for more than 50. This is a very important update from new edition. So above 35, you cannot hereafter say RYGB is a procedure of choice. It is now either you can give fundoplication or RYGB. But another option, another choice is not changed. Sleeve gastrectomy is contraindicated in patients with GERD. Is no change. It is already there. So you should not do sleeve gastrectomy. You can only do RYGB. So managing post-bariatric GERD. Now another update is made in this edition. Patients who underwent bariatric surgery, they may develop GERD, especially sleeve gastrectomy done patients with severe GERD. What will you do for them? As of now, 22nd edition says, if there is a severe GERD in a sleeve gastrectomy done patient, convert to RYGB is the gold standard. Convert that sleeve to RYGB. A new update has been made. Instead of converting sleeve gastrectomy to RYGB, you can put a magnetic sphincter. This is updated now. Magnetic sphincter can be put for these patients with a response rate of 80% at 1 year. So update number 17 is magnetic sphincter augmentation device has been used in post-gastrectomy, post-sleeve gastrectomy patients. And there was a long trial. Every edition they used to write about it. RAP IPF trial. It's a fundoplication in case of idiopathic pulmonary fibrosis. The trial was going on for a long period and the end point was functional vital capacity at 48th week. Functional vital capacity at 48th week. So long awaited results was published. Do you know what happened? The result says laparoscopic anti-reflux surgery is safe and well tolerated in idiopathic pulmonary fibrosis. But laparoscopic anti-reflux surgery did not slow the rate of decline of functional vital capacity. So it does not help in improving the functional vital capacity. So you can do the surgery, but it does not help in declining the functional vital capacity. It does not slow the rate of decline. So that's a progressive disease. Idiopathic pulmonary fibrosis keeps progressing whatever you do. Update number 19, there is a line again below that. There is a study showing laparoscopic anti-reflux will be beneficial in idiopathic pulmonary fibrosis before lung transplant in a group of patients. They are saying before lung transplant, we have to do fundoplication in a group of patients. These patients are those who had pH monitoring showing laryngopharyngeal reflux, pepsin and bile acids detected in the bronchoalveolar lavage, pepsin and bile acids detected in the bronchoalveolar lavage, and these patients may be benefited. Please remember. So when you do a bronchoalveolar lavage, pepsin or bile is present means definitely they will get benefited before going for a lung transplant. So before lung transplant, we can do laparoscopic anti-reflux surgery. So update number 20, when I'm taking class last month in our institute, I had a doubt whether the most commonest hernia among the paraesophageal is type 2 or type 3. So I told in the class also by mistake as type 2, but it is very clearly mentioned in new edition. Type 3 is the most common true paraesophageal hernia. So paraesophageal hernias are type 2, type 3, type 4. Now it's clear in this edition. Type 3 is the most common true paraesophageal hernia. So type 2 is rolling paraesophageal hernia. Type 3 is mixed paraesophageal hernia. Type 4 is massive hernia. Type 3 is the most common, and it is more common in females, and it is more common in obesity and weightlifters, and those who already have a low intrathoracic pressure like COPD. They will develop paraesophageal hernias. Okay. And this is already what we used to write in our endoscopy pictures when we do regular endoscopy. It was not there in old edition, but now new edition has very clearly mentioned a grading system to classify G junction flap valve. G junction flap valve by means of Hill's grading system. So it is an American Foregut Society grading. So L, there are LDF component. L stands for hiatal length. Hiatal hernia length, how many centimeters? Hiatal axillary, hiatal opening length, how many centimeters? Hiatal aperture, that is diameter, opening is how many centimeter? Hiatus hernia going up, how many centimeter? And flap valve shape. So LDF based on L stands for length of the hiatus hernia, D for diameter of the opening, F for the shape. See, please understand, hiatal length is 0 centimeter normally. Hiatal aperture will be snug to the scope with only 1 centimeter gap, and it has a omega shape as you see in this picture. This is a omega shape on, when you do endoscopy, you will have a omega shape of G junction valve. So if the omega shape is gone, there is a flattening of the valve, that is 2 points, and there is fully wide open like this. The valve is fully wide open with a 2 to 3 centimeter gap, more than 3 centimeter gap. So these are all based on this. We can grade the G junction flap valve. So whether the surgery we have done, fundoplication, whether it is normal or not. Grade 1 is intact, grade 2 partial disruption, grade 3 moderate disruption, grade 4 is complete disruption of the G junction valve. So G junction flap valve mechanism, flap valve function can be directed by a Hill's grading system. So Hill's grading, omega shape, we don't read this much in our practice. When it is looking omega shape with a snugged endoscopy on a J maneuver, we say as grade 1 intact. Grade 2 means partial disruption or flattening of the valve like this is grade 2. Grade 3, there is an opening of 2 to 3 centimeter. Grade 4 is more than 3 centimeter opening. We call it as Hill's grading system. So update number 23, CO2 pneumothorax. So this is a very interesting procedure we do in practice. When a patient suddenly develops tension type of pneumothorax during surgery, it means during fundoplication, a small hole happened in the pleura and air entered like a single wave ball valve. Now, what should I do means, don't worry, just open the pleura bigger size and equate to the abdominal pressure. So equate to the abdominal pressure, open the pleura more, no need to go for ICD and all now. Open the pleura more, it will usually resolve. It will usually resolve because it is CO2 pneumothorax. Make the tear bigger, that's the concept. Make the pleural tear bigger. And gastric volvulus, there is a very important update. We used to read whether gastric volvulus means it's an emergency. Gastric volvulus is usually seen with the paraesophageal hernia, and when there is a gastric volvulus, we should operate immediately. Is an old concept. This concept is now changed. The first step is put a nasogastric tube and decompress. By doing a nasogastric tube and decompressing, you have now converted an emergency procedure to elective procedure that can be performed in 24 to 48 hours. So no need to do immediately. This helps in facilitates reduction and repair with non-edematous tissue. Okay. So I have missed update 22. Sorry, I have missed update 22. Paraesophageal hernia is recommended. So previously we used to tell when there is a paraesophageal hernia, you should operate. But now there is an update. Paraesophageal hernia repair is recommended only for patients with associated symptoms or complications. Asymptomatic paraesophageal hernia, you can wait and watch. 22nd update. 23rd is pleural tear. Okay, 23rd is pleural tear. 24th is gastric volvulus. You can wait and operate after 48 hours. This passing of nasogastric tube facilitates hernia reduction and repair with a non-edematous tissues and allows time for fluid electrolyte correction. So with very sick patient, they also updated you can put a double peg tube. Double percutaneous endoscopic gastrostomy tube can be put inside and you can pull it and fix it to the abdominal wall. So put one tube and pull the stomach and you fix to the abdominal wall so that it will not go for rotation. This is for severe sick patients. So this is a gastric volvulus. Some updates are mentioned. So many updates with the tumors that they removed the in old edition 21st. There are so many tables. Separate TNM staging for clinical, separate pathological stage, separate. Now they have removed that and they mentioned very clearly for squamous cell cancer and adeno cancer, only TNM is used. Only TNM is used. For pathological staging, for squamous cell cancer, we use TNM, grade and location. So grade location is included in pathological staging. In adeno cancer, we don't use location because it is in the lower abdomen, lower esophagus. So it is TNM and grade only for pathological staging of the adeno cancer. And post neoadjuvant pathological staging, YPTNM, there is no change. It is same TNM. So the only change is for pathological staging where TNM is added with grade or location. That is for squamous. This is already there in old edition. They have made a simplified table in this edition. So biomarkers are added now. The immunohistochemistry is done with the tissue taken in cancer. I'm telling you, there are so many updates with the cancer related topics. We don't know how much they will ask in the exams, but new edition update has done very clearly. We have to do biomarkers in CA esophagus from the biopsy tissue. Either during post-operative or pre-operative also we can do from the biopsy tissue. HER2 protein is most frequently overexpressed in adeno cancer. HER2 is most frequently overexpressed. Immune checkpoint program death ligand 1 is associated with unfavorable survival. MMR testing is essential. So HER2 program death MMR 3 should be done for all cancer esophagus. And this is a very nice table which is explaining the entire treatment of cancer, adeno cancer as well as squamous cell cancer. This is not changed. Everything is already discussed in our content. In our regular material, I have discussed the same thing. It is same. No change at all. It is same, but they have made a beautiful table to understand it clearly. Yearly cancer of the disease is nothing but TIS and T1A. TIS and T1A involving mucosa only. So T1A is mucosa only. We can go for endoscopic resection plus or minus ablation. Plus or minus ablation. Clinical T1B to T2N0. Clinical T1B to T2N0. So T2N0, well differentiated, no lymphovascular invasion and less than 3 centimeter, we can opt for either endoscopic resection or esophagectomy. So moderate to poorly differentiated lymphovascular invasion more than 5 centimeter, we have to go for esophagectomy. We have to go for esophagectomy. So squamous cell cancer, we also go for esophagectomy for such cases. And locally advanced cases, you can see either we give neoadjuvant chemotherapy or perioperative chemotherapy or definitive chemotherapy. Locally advanced cancers, we go for only definitive chemoradiation or palliative care. So this table is already explained in old edition. And this is another update which is already there in Shackelford. Most common complication after esophagectomy is atrial fibrillation. It is the commonest complication in any thoracic surgery. How much radiotherapy should be given? Definitive chemoradiotherapy. Radiotherapy given is 50 gray. Okay, definitive chemotherapy is so definitive chemoradiation is given for adeno cancer also. There is a definitive chemoradiation given for adeno cancer also as well as for squamous cell cancer also. So either we can do neoadjuvant chemotherapy plus esophagectomy or perioperative chemotherapy plus esophagectomy or definitive chemoradiation. So definitive chemo radiation is the only treatment for cervical esophagus. Please understand, for cervical esophageal cancer, there is no surgery. It's only definitive chemo radiation. So definitive chemo RT means we give 50 gray. So neoadjuvant means 41.4 to 50.4 gray. Palliative means 30 to 35 gray. For dysphagia alone, we give this. This is updated point from Sabiston. Instead of trastuzumab, they have added trastuzumab deruxtecan antibody drug conjugate for as a second line drug for HER2 positive cases. So for HER2 positive cases, if trastuzumab is not effective, we can add an antibody drug conjugate called as trastuzumab deruxtecan is added now. And ramucirumab is already there in the old edition. It is a second line drug for these patients who are VEGFR antibody. So this is given a trial called as REGARD trial shows ramucirumab is beneficial second line drug. So immune checkpoint drug inhibitors or immune checkpoint inhibitor drugs are added, names are added in this. Program death ligand 1 is atolizumab, durvalumab. Program death 1 antibody is nivolumab, pembrolizumab. So previous edition we had only pembrolizumab in the book. Now they have added many new drugs. Atezolizumab, durvalumab. CTLA4 antibody is ipilimumab and tremelimumab. CTLA antibody. So these drugs have clear benefit in squamous cell cancer. Immune checkpoint inhibitors have very clear benefit in locally advanced squamous cell cancer, but unclear evidence in adeno cancer. So now you can see whenever I'm going for a new adjuvant therapy, usually we give only chemotherapy as per old editions. Now there is an ongoing trial, Matterhorn trial, in which immunotherapy is used in neoadjuvant setting along with FLOT4. Durvalumab, the durvalumab is programmed at L1. Durvalumab with the FLOT4, the ongoing trial, Matterhorn trial is going on now. So this is a very important update. I think from Bailey you have already seen this update. FLOT4 is a standard of care in esophageal cancer. FLOT4 is a standard of care in esophageal cancer, adeno cancer, and NCCN recommends FLOT4 therapy for all those who have good performance score. Those who are having moderate performance score, NCCN advises not to use FLOT4. It is toxic. Go for FOLFOX. FLOT4 is best for people who have good performance score. If you are having moderate performance score, go for FOLFOX. Recurrence after cancer esophagus is 90% in 2 years, and mostly it is a distant disease. Local regional recurrence is less common in people who undergo neoadjuvant chemotherapy followed by surgery. So therefore, those who underwent treatment as per cross trial, neoadjuvant chemotherapy followed by surgery, endoscopic surveillance is not needed. Very interesting point, because there is no evidence of local recurrence in these patients. On the other hand, if you have done a definitive chemotherapy, local recurrence is more. Therefore, you must undergo endoscopic surveillance. So these are the 34 updated points from esophagus chapter. So all other points in 21st edition are already discussed. The 22nd edition are already there in 21st edition also. So extra points, new updates alone, I have made it as 34 update points. So if you read only the updates, that is enough. Those are prepared from 21st edition and having strong confidence in 21st edition. Don't worry. We will complete all the updates from the entire book by different faculties, and we will tell you what all to be added up to your original material. That's all. Okay. Stomach updates are very less compared to esophagus. In benign stomach chapter, the author is the same, content is also same. Peptic ulcer, dumping syndrome, gastritis, all those things, no change, because the authors of 21st and 22nd edition, benign chapters are same, no a big update. Just some updates about H. pylori. We were expecting this H. pylori update will come this year, and it has come. So even after H. pylori eradication, risk of cancer stomach persists. It is a group 1 carcinogen. And what is the 3 problems caused by H. pylori means? The most common problem is pangastritis. Pangastritis with a normal acid. That is the most common complication. Number 2 is duodenal ulcer type of phenotype, where there is antral gastritis due to high acid. So normal acid causing pangastritis also there, high acid causing antral gastritis also there. Gastric cancer is a third phenotype, is associated with decreased acid and gastric body predominant gastritis. So H. pylori associated cancer almost always have intestinal metaplasia, and the toxin associated is CAG-A toxin. And that CAG-A toxin is more in Eastern countries than from Western countries. This is an important update. Please don't forget this. Update number 2, CDH1 gene is seen in 40% of the males and 30% of the females. That's another update. Risk of cancer is 40% in males and 30% in females. So diffuse gastric cancer, E-cadherin mutation, CDH1, should advise surgery before 30 years. Please understand, we have to advise surgery for these patients before 30 years. If patient is not willing for surgery, the biopsy protocols are added in new edition. Please know the biopsy protocols. Like we have Seattle biopsy protocol for Barrett's, here there is a Cambridge biopsy protocol and Bethesda biopsy protocol. So Cambridge biopsy protocol says target biopsy of all the lesions. Whenever you see a lesion, take multiple biopsies plus 6 random biopsy from the 5 anatomical locations. What are the locations? Fundus 5, fundus 6, cardia 6, body 6, antrum 6, pylori 6. So 5 locations, take 6 biopsies called as Cambridge. Bethesda, target biopsy of all lesions. In Cambridge, we take 6 biopsy. Here, 4 random biopsy from 22 different sites. There is nothing mentioned about the 22 different sites. Probably they would have mentioned greater curvature like that, lesser curvature here. Like that, they have made 22 different sites for Bethesda protocol. So this is a complicated thing. We have to do annually this. Instead of this, going for a prophylactic gastrectomy is easier. You should advise them to undergo prophylactic gastrectomy instead of following this Cambridge and Bethesda protocol. CDH1 cases should also undergo MRI from the age of 30 because there is a risk of lobular cancer. From which age they should undergo screening means from 30 years. There is no update on prophylactic mastectomy in this edition. They mention MRI from 30 years. A new update called as GAPS. GAPS is a gastric adenoma and proximal polyposis of gastric fundus and body. It's a new syndrome like a familial adenomatous polyposis. Here is a GAPS syndrome. So GAPS syndrome has hundreds of polyps in the proximal stomach. Gastroscopy should be started from the age of 15 and total gastrectomy should be done before 3rd decade. So this is a condition like FAPS, familial adenomatous polyposis of the colon. Same way, gastric adenomatous polyposis of stomach is mentioned in new edition. GAPS, do surgery before 3rd decade. So Lawrence classification is diffuse intestinal. Now modified Lawrence they have added saying 2 types of diffuse, proximal non-diffuse, distal non-diffuse. Proximal non-diffuse is worst prognosis, distal non-diffuse is good prognosis. This classification is better predicted than histological classification. Please understand, modified Lawrence is updated in new edition. I told you there are multiple types, subtypes, molecular types are added in this type of cancers nowadays. So 4 types of molecular subtypes are added for gastric cancer by the Cancer Genome Atlas. They are Epstein-Barr virus positive, microsatellite instability, genomic stable, and chromosomal instability, CAN. So in this, CAN exhibit intestinal histology with a high prevalence of P53 inactivation. MSI tumors, please remember, microsatellite instability tumors are not respond to chemotherapy. No use of giving chemotherapy to the microsatellite unstable cases, but they respond very well to immunotherapy. Microsatellite unstable and Epstein-Barr virus type are responding to immunotherapy. So this is again another flow chart which is also there in old edition. They made a clear-cut concept of how to manage diagnosis of gastric cancer by multiple methods. Suspect yearly disease means you should go for endoscopic ultrasound. So clinically T1 or T2 we can do endoscopic resection. So standard criteria, extended criteria we have discussed in 21st edition, same is there. Standard criteria, extended criteria. So sometimes even for a yearly disease who is having submucosal invasion and T2, they are taken for gastrectomy. So suspected locally advanced cancer, go for a diagnostic laparoscopy or PET-CT. It is only locally advanced means not microsatellite instability or Epstein-Barr virus means you can give neoadjuvant chemotherapy. If it is a microsatellite instable or Epstein-Barr virus means positive means that cases you should take for upfront gastrectomy. This is an important update. You should not forget this update. So if microsatellite instability is present and Epstein-Barr virus is positive, take gastrectomy directly. Afterwards, you can give immunotherapy. Or you should go for neoadjuvant versus neoadjuvant chemo plus or minus immunotherapy. So neoadjuvant therapy is helpful only for selected cases. So this is about the same table which I told you before. So microsatellite tumors are not responsive to chemotherapy. Microsatellite unstable tumors respond to immunotherapy only. So immunotherapy is responsive. So you can give neoadjuvant immunotherapy for these patients. So this is a very important update based on MSI and EBV. We have a small change in management and margins are given very clearly in this edition. Clinically, T1 means 2 centimeter margin enough. For T1 cases, 2 centimeter margin enough. T2 to T4, non-infiltrative type, 3 centimeter enough. 5 centimeter is needed for infiltrative or diffuse gastric cancers, 5 centimeter needed. Margin equivalence 5 centimeter. Previous edition, they didn't mention this accurate margins. In 22nd edition, they mentioned the margins 2, 3, 5. Okay. See, Koreans made a trial I discussed in 21st edition called as class trial. So class trial was a trial comparing a proximal gastrectomy with a total gastrectomy. So previously, so there was some issues we have discussed in that trial. It is not favoring proximal gastrectomy in class trial because the major reason was class 1 trial had a major complication of severe reflux into the esophagus. If to understand class 5, you should read class 1. Class trial, which was a proximal gastrectomy versus total gastrectomy and anastomosing esophagogastric or esophagojejual. That is abandoned. That procedure was not so beneficial. Proximal gastric cancer resection was not done. So now they did a small correction. See, they did a proximal gastrectomy and they didn't anastomose the stomach with the jejunum. They brought the root limb of jejunum and anastomose with the esophagus. So esophagojejual and this gastrojejunal and there is jejunojejunal. So what happens therefore in this case? In this case, the gastric reflux is less and therefore the esophageal complications are not seen in this concept. So they are saying class 5 trial compared laparoscopic total gastrectomy with the laparoscopic proximal gastrectomy with the double tract reconstruction for early gastric cancer and showed similar morbidity without a significant difference in anastomotic complications. In Korean class 1 trial, there was anastomotic stricture. Here, there is no anastomotic stricture. With a decreased need of B12 supplementation with a double tract reconstruction arm. This is a picture newly updated in Sabiston 22nd edition. Double tract reconstruction. There is another interesting trial. See, I'm telling you, if you to understand the updates, you should be strong in Sabiston 21st edition. To understand the updates, you should be strong in Sabiston 21st edition. So Cardia trial will compare. See, what is done for CVET 1 and 2? CVET 1 and 2, we do transhiatal esophagectomy. So for CVETs 1 and 2, we do transhiatal esophagectomy, and CVET 3, we do total gastrectomy. So Cardia trial will compare transthoracic esophagectomy versus, please understand, for a type 2, they are doing transhiatal gastrectomy, extended gastrectomy. They remove the entire stomach along with some part of esophagus. Based on this current evidence for CVET 2, with the esophageal extension of 2 to 3 centimeter or less, gastrectomy via abdominal approach with a transhiatal resection is oncologically appropriate. It's a new update. Cardia trial is explaining about the treatment of cardia tumor, especially CVET type 2 tumor. To understand this update, you should know CVET 1 and 2 were done esophagectomy. Now it is modified. It is modified. So open gastrectomy is preferred over laparoscopy in the following cases. So we used to discuss laparoscopy, open, anything can be done. But in this update, there is a clear concept. Don't do laparoscopy for T4B and N2 bulky disease. T4B involving adjacent organs and N2 bulky disease, go for open gastrectomy. Okay, that is a very important update. Recurrences are most common in distal or peritoneal sites. In gastric cancer also, like esophageal cancer, recurrences are common in distant sites or at peritoneal sites. Local recurrences are less common after D2 compared to D1. So NCCN, the same recommendation. FLOT 4 is given for good performance status. FOLFOX for moderate to good performance score. So this is a very important update. Same we saw in esophagus also. FLOT 4 compared MAGIC trial ECF, and this edition, this update is there in last edition itself. So 4 cycles are given pre-operatively. This is a 4 cycle given pre-operative and 4 cycles given post-operatively, improved the overall survival of FLOT 4 arm. So FLOT 4 is better than ECF MAGIC trial. So we have already discussed ARTIST trial in old edition. In old edition, they mentioned ARTIST trial of giving radiotherapy. They mentioned radiotherapy is not good, no benefit of adding radiotherapy. Now ARTIST 2 did a small modification. He did radiotherapy only for node positive patients, and he compared surgery plus oxaliplatin versus surgery plus oxaliplatin plus radiotherapy. No benefit of adding radiotherapy. ARTIST 2 trial is also a failure. No benefit of adding radiotherapy in an ARTIST 2 trial for a D2 done cases. NCCN recommends radiotherapy to be given only if less than D2 lymphadenectomy performed. Otherwise, don't give radiotherapy. No use. No use in node already removed cases. ARTIST 2 trial is about the adjuvant radiotherapy. So new NIPIJA and Infinity trial. See, this is a problem with the new editions. When the new edition comes, no, they will start publish. These oncology people, they don't have, their main job is to do some study and publish that. Whether it is useful or not useful, they will publish it and it will come in the book. So these are all from Devita Oncology. There will be full of discussion on this only. Luckily in Sabiston, we have only the names and a few lines. New NIPIJA and Infinity trial show 60% pathological response rate with a microsatellite high instability patients with a neoadjuvant dual checkpoint inhibitors. Very important update. Infinity and NEO-NIPIJA trial talks about microsatellite instability having gastric cancers benefit with neoadjuvant 2 drugs. Program DEATH1 and CTLA for 2 drugs can be given as neoadjuvant in MSI-H cases. Because MSI-H cases will not respond to chemotherapy, we should go for immunotherapy. Petrarca trial. Petrarca trial is a more complicated trial. They tried 2 HER2 antibodies, trastuzumab plus pertuzumab along with FLOT 4 as a perioperative regimen. Farmer group of adding 2 monoclonal antibodies with the FLOT 4 had severe complications like diarrhea and leukopenia, and they stopped the trial. Petrarca trial and Jacob trial both are abandoned. They are not so good. They both are abandoned now as per 28th edition update. So update number 19, MALTomas with H. pylori negative. What is the next line of management? MALToma H. pylori negative means we will give radiotherapy in all the involved sites along with CHOP therapy. Now they added MALToma prognostic index is based on 3 risk factors: age above 70, stage 4 disease, and elevated LDH. These are 3 primary risk factors of MALToma prognostic index based on age 70 or above, stage 4 and elevated LDH level. So don't forget, this is a small update in 19 from the 22nd edition. So PDGFR8 D842V mutation, we had a drug mentioned in 21st edition called as dasatinib. That is a drug mentioned in old edition. In this book, they are mentioning avapritinib for GIST. Avapritinib for GIST, they are mentioning for D842V mutation. If there is exon 11 mutation, 400 milligram imatinib is enough. Exon 9 means you should give 800, double the dose. Double dose is given for 9. Okay, remember, double dose is given for 9. 11, 400 milligram. Avapritinib is a new drug for D842V mutation. So these are the updates which we saw from stomach chapter also. So very few updates in stomach. So majority of the updates in new editions are not related to anything. They just mentioning the trials. and the change in the chemotherapy regimen. That is what the major headache. So you'll be having in this preparation. So, but whatever it is, don't forget the landmark trials. Usually the examiners will not try to ask any new trials. They will ask questions from landmark trials like MAGIC trial, CROSS trial, like that only they used to ask. FLOT 4 is a new regimen used for esophageal and squamous cell cancers. This completes the esophagus and stomach update. So we'll be doing regular updates in this. So please keep following this channel. We'll be updating whatever new updates coming will be posted in this, and all these videos will be available. We will not be deleting this YouTube, and please go through please go through this Telegram channel. That's our Telegram channel. I hope you are there in our WhatsApp group. All the WhatsApp groups we have. So please remember, this is our Telegram channel. In this Telegram channel, I will upload all the update questions. I'll upload in this. Okay. So please go through this updates there. So thank you so much. See you soon. I am also reading along with you. Always I'm having the book. We splitted the book. What happened now? We have no PDF. So we bought the book and we cut into 8 pieces and we sent to 8 different faculties. So 8 different faculties are doing their job. So we will be I am doing the GIT and HBP part, and there are some faculties doing oncosurgery. So exam dates, as of now, we don't have an idea. Probably it will be in the month of probably it will be in the month of December. So no, it's not sure. We cannot say anything on this exam dates. But as you know very well, many colleges, they are finishing the exam by only December. So I will share the PDF now itself. Don't worry. You can download from the Telegram channel now itself. Okay. So thank you all. So as of now, no offline classes because we have no idea when is the exam. So once we have an idea about the exam, we will announce the next offline class. Thank you. Thank you. Bye.
Recording stopped.
Thank you, sir.
Thank you. You can stop.